Being a smoker and a drinker, I consider myself a drug addict.
Well, it's not so much that I think they're mentally ill. I just think that they encourage the young to join them in their, in their habit.
Do you think they committed a criminal offence and should they go to prison?
Well, I think that's putting it a bit strong. The offence they've committed is that younger people might think it's something big to do and they might follow in their footsteps.
I think they're idiots.
Do you think they're mentally ill?
Yes.
Should they go to prison if they've committed an offence?
Yes, quite definitely, for a very long time.
What do you think about the dealers who push drugs to teenagers?
Should be shot.
So that's what some people think about drug addiction. Well, it's quite true, it can seem a perplexing subject. And in this part of the programme, we want to look at the fundamentals, that is, the psychological dependency and the physical dependency.
I think it's important when we're talking about using drugs that we consider the reasons why people might have started to use, those which might mean that they continue using, and even reasons which might make them return to drug use after a period of abstinence. It might be that there are different reasons in all three of those areas. But I think within each of those areas, we might be able to break that down further into psychological reasons, physiological reasons, social, psychosocial reasons. And I think that some of the ones that have most commonly talked about are perhaps in the physical area, people who might begin self-medicating for a real or psychosomatic illness. People who perhaps suffer from panic disorder may have been self-medicating with some sort of substance, either prescribed or illicit, and again the dependence then takes over from the initial disorder.
I started using when I was 14, 15 with my mum. My mum's a barb addict. And it sort of, when she killed herself, it went wild from there, really. I'd say for the first 8 years of my drug taking, I really enjoyed it.
What does it do for you?
It gave me a sense of freedom. It gave me friends. It gave me a new, different lifestyle. It also gave me excitement as well. A lot of excitement. And as I say, like, it wasn't for the first 8 years of my drug taking, I really enjoyed it. I loved it.
What were the disadvantages?
Waking up in the police station in West End Central, asking why I'm there, and then being told that I'd been there I was shoplifting a few hours before, just so I could get money to buy my next fix with. I was given a section as well when I was 20, I think 21. I was sort of like locked in a locked up wall for a couple of weeks with people that weren't well at all. And here am I, and there I was saying to myself, well, why am I there? Why was I there? Why was James there? You know. There's lots of things. I mean, I'm married now, and for a couple of years I did stop taking drugs. When my father died, I stopped taking drugs. That was back in 1979. I went to Alpha House as a rehabilitation unit. I actually stopped for 2.5 years, even though I was drinking. I didn't take any drugs. I felt pretty good about that. But I ran out of excuses. That I kept giving myself the same old excuses all the time. And in the end, I believe that people like myself, we run out of ourselves in the end because we come up with all the answers that we can possibly think of.
Although these problems of personality, which may be linked to difficult mother-child relationships, difficult relationships with fathers, possibly with chaotic families, although these problems may have generated the problem to begin with, one also has to deal with the whole issue of how the drug dependency to some extent maintains itself in a kind of vicious circle. So I think it's important to hold in mind the two factors, the fact that addiction has been developed over time to learn to cope with problems in the individual and in the social network, but equally there are problems of withdrawing from the drugs itself, which actually maintain drug addiction in the present.
While we're talking about psychological bases for addiction, I think it's important not to overlook the fact that drug use is a learned behaviour in part, and for some people it might well have been that continued drug use has followed on from a fun episode with peers, part of experimentation. For most of us, if we try something and it's good enough, we'll want to try it again. And very often I've heard particularly opiate addicts say that they used initially because they enjoyed it, but that their use when it got into the sort of maintenance phase of their dependence was for quite a different reason. Their use then was not for enjoyment, but was in fact to avoid pain or discomfort. So I think that perhaps highlights how we must look at the initial reasons and the continuation. But certainly fun is a good psychological reason for doing something. In terms of the social aspects of drug use, I think it's important not to overlook that very often drug use brings with it a ready-made peer group, a ready-made social outlet, a club if you like. And at the same time, some people who use drugs might have found that difficult to achieve sober, if you like. I mean, we all know of the term Dutch courage in relation to alcohol, but certainly any substance which suppresses anxiety is going to be a social facilitator for a while for people who might have a problem with mixing and with anxiety. So I think your initial question is a very complex one. We need to look at it in the different stages of drug use over time for an individual, and we need to look at it in terms of psychological, social and physiological aspects of that person's makeup.
And I have with me Dr. Woody Khan, who I hope is going to tell us something about the physical dependency. So, Dr. Khan, what changes do you notice in somebody who is dependent?
Andrew, physical dependence is a major obstacle to the rehabilitation of the drug-dependent individual. If they have a past history of unpleasant or frightening withdrawal experiences, then they'll be extremely reluctant to risk reduction of their drug use in the future. Most drugs of abuse act at very specific sites called receptors in the brain on the external surface of nerve cells. These receptors usually interact with minute quantities of the brain's own neurotransmitters. These interactions are very brief and only involve a very small subpopulation of the potential receptors for these neurotransmitters. When you take an exogenous drug like heroin or Valium in high doses for long periods, this is a very unnatural state because many of the receptors are affected for a long time. It's not surprising that physical changes occur in the brain in response to such a bombardment with powerful chemicals.
So the whole concept of physical dependency is very real and people should take notice of it.
Yes, if you consider that picogram quantities of enkephalins are involved in the healthy functioning of the brain, but that a heroin addict may inflict more than a gram a day of heroin on his brain for years, it's not surprising that many adaptive and maladaptive changes may occur. An agonist is a drug that mimics the action of a neurotransmitter in the brain. It produces some positive action on a receptor. An antagonist blocks the action of the neurotransmitter or the agonist, and an inverse agonist has the opposite action of the agonist. These three classes of drugs are all relevant to work with sedatives. Valium is an agonist at the benzodiazepine receptor. Flumazenil is an antagonist, which does nothing on its own but prevents the binding of Valium. Harmaline or other beta-carbolines are inverse agonists which produce the opposite action of Valium.
What sort of symptoms might a patient have that you gave an inverse agonist to?
In the case of the benzodiazepine inverse agonists, such as Harmaline, they'll become fearful, their seizure threshold will be lowered, they'll be sleepless and stiff and tense. The opposite picture that you'd see of Valium causing a lowering of anxiety, sedation, muscle relaxation, and a raising of the threshold for any seizures. Some substances may trigger the production of beta-carbolines within the brain. Alcohol is metabolized into acetaldehyde, and after a heavy drinking bout, acetaldehyde causes condensation reactions to generate beta-carbolines within the human brain that are likely to produce states of fearfulness, to precipitate seizures.
Initially, when you first take heroin, you can go for about 3 months and you stop, and it's like a little bout of flu. So it's nothing major, so it's not a problem initially. But after, say, 6 months to 9 months, your habit will increase because you need more and more to get high. And then it does affect your body badly. And after a period of, for me, for about 2.5 years, I tried to come off. I had terrible pains in my muscles, in my back, my kidneys, my liver, my legs. It was as if my body was screaming in pain. You would do anything to relieve that pain. Anything, 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 anything.
Two things initially. I think the first is to try to remove from your mind the worst of the media coverage, that most of the people that we see are not likely to run amok being abusive, aggressive or smashing the place up, and that very often they will feel stigmatised themselves. So I think the style of your initial approach is the crucial thing, and that you should try to be non-condemnatory, not to be anxious yourself, and above all to recognise that if you don't succeed in getting someone to admit that they want treatment, it's not necessarily a professional failing on your part. That one of the key factors about drug dependence is that people are very ambivalent about whether they actually want to do something about their drug problem.
It's important to try and, first of all, address what are your attitudes to drug takers. I mean, to have a kind of fairly open assessment of your own drug taking or alcohol taking or whatever, however limited it has been.
There is anxieties working in the area. There's sort of the misplaced attitudes that drug addicts are violent. You know, they have a tendency to be aggressive. And I think I know I came in maybe with some of those feelings and being quite uneasy. And they get dispelled. I think really it's coming with the open mind.
Well, the initial steps obviously would be to make an assessment of the patient's presenting problem. One would not want to leap in to prescribe methadone unless there are indications to do so. So in other words, assessment would be to take a history from the patient, to take urine samples for toxicological analysis. Physical examination can also provide some indications of drug use, such as injection marks, although there may be nothing very specific on physical examination.
It also says that if a patient comes in who is sober, and sober meaning they're not falling over or they're not disinhibited, etc., and we take a urine sample from them, and that urine sample comes back with being positive for heroin, in quite large quantity of heroin, we would then indicate from that there is the high probability that they have quite a heavy tolerance, in that we saw them normal or sober, and they had actually quite a lot of drugs on board when they actually came in and gave that urine sample. The reverse side of being is if somebody came in intoxicated and we took a urine sample at that point and there was only a trace of heroin in their system, then one could possibly deduct that they had a very low tolerance. Now that's quite crude, because we don't just go on the drugs and the drug screening. We also obviously take objective science and a history. A full history is taken from the nurse, the social worker and the doctor. So I mean, that's just really something to back up what we're taking verbally and objectively by looking for signs.
We would prescribe methadone in patients who we have established have dependence on opiate-type drugs, and we would use methadone as a tool for detoxification. That would be both inpatient and outpatient, and we're talking over a fairly short time scale, say 2 to 4 weeks. And we would also prescribe methadone for outpatients on a longer term basis in the context of a treatment contract, whereby the patient would be stabilised on methadone, continue to attend the outpatient clinic and gradually come off this over a period of several weeks or several months. It would be our recommendation to prescribe it in oral form, and of the 2 forms available, we would advise the liquid 1 milligram per ml mixture form, as the tablets can be crushed up and injected. To establish the appropriate dose for the patient is a matter of adjusting the dose according to individual needs. From history alone, it isn't possible to have established that a particular dose is the right dose.
When a patient is withdrawing, one of the simplest ways to gauge the level of withdrawal is simply to look at their eyes, look at the pupils. When a patient is using opiates, when they're intoxicated, the pupils are very, very small, we call pinpointed. When they're withdrawing, however, the pupils are very large, they're very dilated, and that's one of the simplest, most accurate signs of a withdrawal from opiates. Other signs to look for are what we call goose flesh or piloerection. That's the sort of thing that you might see on your own skin on a cold day. The patient may have a runny nose, what we call rhinorrhea. You may see the patient yawning quite frequently. You may find that the patient produces tears profusely. It's called lacrimation. As regards psychological signs of withdrawal, well, the patient will be craving drugs. That's very, very common. The patient may be talking about them, thinking about them and so forth. He or she will often be very agitated and very restless, two very, very common signs. Other things to look for, many patients are nauseous, some patients vomit, many patients have diarrhoea. Those are the main symptoms of a withdrawal.
We strongly advise that methadone is prescribed on a daily dispensing basis. In other words, the patient should be introduced to a local chemist who is agreeable to dispense methadone for him every day of the week except for Sunday. There are special prescription forms available to general practitioners which allow for the facility of daily dispensing. Clearly, as methadone is a controlled drug, the general practitioner must comply with the regulations concerning the writing of prescriptions for controlled drugs, which is the patient's name and address, to be in the doctor's handwriting, the total dose to be specified in words and in figures, and obviously to be dated and signed by the general practitioner. Non-opiate detoxification, that is using drugs again such as the phenothiazines to provide symptomatic rather than specific relief, could be appropriate for a patient who one feels has a minimal, if any, physical dependence on opiates, but who is nonetheless using drugs. Also, in some occasions, patients who have an established addiction do say, I don't want to take the addictive drug methadone, I would like to try some less addictive medication. And it's certainly worthwhile to give this a go.
Well, I mean, that would depend very much on quite a detailed assessment of the nature of the drug taking. That is to say, the causes of the drug taking in the here and now and within the total family situation. Because psychological treatments can be framed either within an individual context, or if there are major family difficulties, to try and include the whole family within the picture of treatment.
Are you saying that it'd be important to include the whole family?
I think certainly at the assessment stage, I think that is important. If the individual does have a family situation, I think it is important at least to incorporate some understanding of them at the beginning of the treatment to see exactly whether drug taking fits into the overall system rather than to assume that it's purely an individual problem to begin with.
I think they're two very important issues. The first one is one that's addressed very much by Families Anonymous, And that is the concept of tough love. The idea of saying to someone, I love you but not your behaviour. And really helping the family to look at themselves and to see whether there are ways that they're inadvertently colluding with the drug use. For example, by rearranging family routines around drug use or supporting it financially in one way or the other. So for families to recognise that and be assertive enough to stop it is very important. I think the second area is to look at the way the identified client, if you like, fits into the family system and whether or not they are being inadvertently scapegoated. They are carrying all the family pathology with a small p, and the drug misuse is the pot into which all the family troubles are poured. If that's the case, then there are going to be ways in which the family will lose if the person stops taking drugs, and this has to be remedied. If we take an example of a family where there is not a very strong relationship between the parents, the identified client is still at home, and when he's using drugs, the relationship between the mother and father improves because they focus their worry on the son. So they don't argue between themselves. The father is very rarely at home, if he can help it, but will stay at home when the son is particularly ill and in trouble. So the mother of the drug user gains because she has her husband around all the time and argues with him less. The more involved with drugs her son actually is.
Well, obviously, I think it's a good question because, I mean, on the one hand, one is trying to think of the family's needs, but also have to think of the needs of the specific individual at the beginning of treatment. And so I guess it's important to try and understand what it would mean to them to involve the family to begin with. Because if you rush too much to involving the family, that can sometimes create problems for the individual contacting and making contact with the agency. So I think it's important to hold in mind the family at the beginning and that they might be part of the treatment situation. But I think it's also important to, you know, your first priority is to gain contact, I guess, with the client.
Well, my family didn't know anything about it, and I basically kept everything from them because if they even knew that I'd smoked blow, they would be devastated because for them it's just like drugs, end of your life kind of thing.